Welcome to Milestones, your daily holiday snapshot of pediatric nutrition breakthroughs. Today, Professor Andrew Prentice is joined by Professor Josef Neu to explore preterm nutrition and how optimized early feeding can transform outcomes for the smallest patients.
Hello, and welcome to another episode in our podcast series, Milestones in Pediatric Nutrition, part of the wider series of NNI Bites Big Learnings. In this series, we get some of the world's leading scientists, physicians, and health policy advocates to share their perspective on discoveries that have really advanced the field of pediatric nutrition. Today, our milestone concerns advances in preterm nutrition, a discipline that has been advancing for over a century, with huge improvements, especially improvements in survival rates and positive outcomes for premature babies. But, as you'll hear, with room for further advances. Our expert today is Professor Josef Neu. Joe, welcome to today's podcast.
Hello, Andrew. I'm very happy to be here.
It's great to have you. Professor Neu is a professor in the Department of Pediatrics, the Division of Neonatology at the University of Florida. He received his Bachelor of Arts degree in 1971 at Wisconsin State University. And then in 1975, he received his medical doctorate at the University of Wisconsin in Madison. Dr. Neu completed his pediatrics residence at Johns Hopkins, Baltimore, followed by a postdoctoral fellowship in neonatology at Stanford University Medical Center. Both of those, of course, are world-leading institutions. Dr. Neu has received during his career many honors and awards and has chaired many national and international committees. His current research interests include precision nutrition for premature babies, and I hope we can get to that at the end, Joe, using artificial intelligence and multiomics, and he's the principal investigator of the Connection trial, an international prospective randomized trial designed to decrease major morbidities and mortality in preterm infants. He's also the chairman of the board of Hippocrates Foundation, involved in global educational activities. Huge kudos to you, Joe, for all of that. Let's start with some of the first ever work on feeding premature babies. I've read, Joe, that 150 years ago, such babies were called weaklings and had a huge mortality rate. Things then started to change in the late 1800s with some work in Paris, I believe. Tell us about those very early days.
Yes, so in those very early days, there was not a field of neonatology. There were obstetricians, people who would deliver babies and care for mothers, but they also played a role in taking care of babies. And so babies that weighed less than 2 kilograms generally did not survive. And there were many reasons for that, but one of them had to do with thermoregulation and keeping these babies warm. Of interest is the fact that one of these obstetricians in Paris, name is Dr. Tarnier, went to the Paris Zoo and noticed that in the bird area, the poultry area, they had these incubators that they used to keep the very newborn birds alive. And so it was thought that perhaps that this technique, this box that was being used at the Paris Zoo, could actually be applied to these weaklings or premature babies, small babies. And so they tried this, and they were able to markedly decrease the mortality of these babies by using this box. They were able to decrease the mortality by 1/2 just using this box.
Wow, I'd never heard that before. I'm presuming that's the forerunner of today's incubators.
Yes, yes.
Excellent. So warmth was important.
Yes.
I also read
One other point of interest here is that if you go forward just a few years to the World's Fair in Coney Island, this was not yet being applied generally in hospitals, but at the World's Fair in Coney Island, they had an exhibition of premature babies in these incubators, just as a novelty, rather than anything that was being used extensively at that time.
Wow. So they got a if you like, a doubling of the survival rate. Fantastic. And I guess there were other things, protection from infection and nutrition, which of course is going to be the main topic to discuss today, which were also critical. How did things move on from there?
Well, as you mentioned, infection, hand washing, it was just one of the very, very important changes that people began to recognize that if they did wash their hands and handled these babies in a clean manner, that this would also help improve their survival and their well-being,
Hmm.
decreasing infections. As
And
time went on, there were techniques applied in the delivery room where the more organized ways to resuscitate these infants and shortly after birth. That was a very important breakthrough. But the field of neonatology really did not flourish until the very early 1960s. And there was an event in the early 1960s where John F. Kennedy and Jacqueline Kennedy's baby died of respiratory distress. And this was in about 1962.
mhm.
And there was nothing that could be done to save that baby. And that baby was born at around 35 weeks gestation, which is almost unheard of
Mhm.
these days, a baby dying at 35 weeks gestation due to respiratory distress, at least in the United States.
And so how did they overcome that, Joe?
Well, one way that they overcame that was by the use of uh, oxygen, mechanical ventilatory techniques, use of continuous positive airway pressure, where you apply a little bit of pressure to the alveoli, because with respiratory distress syndrome, one of the major problems is keeping the alveoli open rather than atelectatic or in their crumply form if you don't have surfactant present, which is something that develops over time. And then also the use of surfactant
Mhm.
uh, became a huge, huge factor in terms of survival of these babies and decrease in respiratory distress. And still to this day, I am amazed when we put surfactant into the airways of a baby who has respiratory distress, how we see that baby improving, from struggling to breathe, to being able to breathe almost normally with surfactant use.
So, Joe, I believe there have been huge improvements in mortality and other outcomes for premature babies. Can you just give us a feel for that?
Well, just to begin with all babies in the early 1900s, the mortality was around 40 over 1,000. Now it's less than 5 over 1,000. But with premature babies, over the past 20 to 30 years, we have been seeing a marked survival in babies less than 28 weeks gestation. And now we are seeing in some hospitals survival of babies down to 22 weeks gestational age. And in some hospitals, it's better than 50% survival at 22 weeks gestation.
That is truly remarkable. I must say, Joe, I have a sort of vested interest in this. My youngest daughter was 9 weeks premature. She's now doing great at the age of 16. She's even a champion cross-country runner. But
Wow.
she would never have survived without the care of people such as yourselves and the very dedicated neonatologists. Absolutely fantastic. Now, let's turn to nutrition and return first to a bit of the history, and then we'll bring ourselves up to date. After the initial work, which you've already described, there followed some intriguing experiments where tiny premature babies could be put in bell jars to measure their energy, their oxygen consumption, and hence energy needs. Um, we'll talk about that in a while, what the energy needs are. But before that, let's review a couple of controversies as the field developed. The first concerned the belief that breast milk was the only viable food for premature babies. What's the story there?
Yes, well, this was the case at one point, and it was certainly recognized with the Industrial Revolution and with mothers being much more involved in the workforce, that there needed to be some substitutes for breastfeeding. And so uh, over time, we started to develop some substitutes, such as the use of Karo syrup, evaporated milk types of formulations. And then industry got involved and started to develop these commercial formulas, which were they attempted to fashion these formulas to the mother's milk, to breast milk. They've improved over time, but they're certainly not quite there yet.
So still breast milk is the preferred, and we'll come again to that in a short while, but the idea that breast milk was the only viable food, that evolved. The second
Yes.
controversy that I read about, Joe, which seemed rather remarkable, was that um, there was a theory that food should be withheld for the first 12, 24, or even 72 hours after birth, until this was later proven to be harmful, which I think surprises us now that it would have ever thought not to have been harmful.
Yeah, so in fact, Andrew, in some premature babies, enteral feeding through the GI tract was withheld even for weeks.
Oh my goodness.
And that was made possible because of the development of parenteral nutrition, intravenous
Oh,
nutrition.
I see. Yep.
Um, and with intravenous nutrition, we were able to provide glucose and amino acids and lipids intravenously, in addition to some minerals, calcium and phosphorus. So I think that physicians became complacent and sometimes did not use the gastrointestinal tract because they were afraid that these babies would not be able to tolerate the enteral feedings. But over time, we become more and more cognizant of the fact that food in the gastrointestinal tract is extremely important for many reasons. One of the reasons is something called a trophic effect. In other words, if you do not put food into the gastrointestinal tract just does not grow.
Mm,
It also stimulates the development of the mucosal immune system. It maintains integrity between intestinal epithelial cells so that you don't have a leaky gastrointestinal tract, which can lead to systemic inflammatory responses and also increase the chances of translocation of bacteria through the gastrointestinal
mhm,
tract
mhm,
and increase the chance of sepsis.
mm. Another
So, uh, putting food in the gastrointestinal tract has been something that we have been working very much on to try to get food into the gastrointestinal tract, especially mother's own milk, very early after birth.
great. With the colostrum, of course, if possible,
Yes,
lining that gastrointestinal tract with IgA and so forth. Good. I guess that's
yes,
another example of use it or lose it. Now,
yes.
Joe, we'll come back at the end to get you to give us, the current best recommendations for practice, but let's talk about the energy needs next. Can you give us a feel for some of the numbers and compare that to other life stages? And from seeing you lecture, I sense that we're going to have a mention of a Tour de France cyclist somewhere along here.
Yeah, yeah. So it's very interesting that using some of these indirect calorimetry methods that you mentioned before, where you measure oxygen consumption, CO2 production in a jar, uh, scientists were able to determine that these babies' nutritional needs were actually quite high. And on the average, premature babies' caloric requirement is around 120 calories per kilogram per day. Now, if you equate that to a Tour de France cyclist on a daily basis requires 7,000 calories
Hmm.
during that day. And if you assume that the Tour de France cyclist weighs 60 kilograms, then that cyclist is taking in 120 calories per kilo per day, which
Amazing.
is similar to what a premature baby requires. But that premature baby is not riding a bicycle all day. That
Absolutely.
premature baby also requires these that increased energy for growth. Uh, some of these premature babies will triple their body weight in the first 3 months after birth. So you can just imagine on a per kilogram basis, the amount of energy they require.
The
And the
energy
same
requirements.
holds true for protein. Protein, they require approximately 3 to 4 grams per kilo per day of protein, which on a per kilogram basis for adults would be extremely high.
And what about their kidneys? I mean, we often, I'm not a clinician, but I am a nutritionist, I guess. And of course, high protein intakes can be associated with difficulties with renal, uh, disposal of urea, etc. Are they okay, the premature babies?
Yes, yes, they actually
Mhm.
are. They are okay with 3 to 4 grams per kilo per day of protein. Uh, we are much more concerned with other factors in terms of their kidneys, such as some of the antibiotics that we give to these babies.
Mhm.
Unfortunately, we're so afraid of infections that we use antibiotics almost routinely in all babies less than 32 weeks gestation. But usually the protein loads are not damaging to these babies. And we find that giving 3 to 4 grams per kilo per day by the enteral route, and even parenterally through the intravenous route, is
Mhm.
okay.
Okay, that's amazing. And fats and essential fatty acids, they're also needed.
Yes, yes. So the metabolic capabilities of premature babies in terms of taking essential fatty acids and desaturating them and elongating them into the long chain fatty acids such as docosahexaenoic acid and arachidonic acid are somewhat limited. And if we do not enterally feed these babies with lipids, some of the lipid preparations that we give to them intravenously
Mhm.
do not provide the type of lipids that are required, the linoleic and linolenic acid. These are the essential fatty acids. And if we withhold lipids early on, and this was common practice in the early days of neonatology, it was found that many of these babies were becoming essential fatty acid deficient. And so now, in the past 15 to 20 years, we have become much more cognizant of the potential for essential fatty acid deficiency, and we provide more lipids to these babies early on, shortly after birth.
So, Joe, this series is called Milestones, and I'm interested in the scientific process, if you like. So, why? Let's take this example of the fatty acids. Why was it considered that you shouldn't give fats and fatty acids, and then what changed that? Was it just sort of experimentation, observation? How do we make
Uh,
change in such a critical area as caring for premature babies?
That's a great, great question. So, in the early days of neonatology, we neonatologists were just afraid that doing something new, such
Mhm.
as giving lipids intravenously, could cause problems. So, to give you one example, giving intravenous lipids was thought to actually uh, the fatty acids from the intravenous lipids could displace bilirubin from the albumin molecule.
Mhm.
And if it displaced the bilirubin from the albumin molecule, that bilirubin could then get through the blood-brain barrier and cause a disease called kernicterus,
Oh,
which causes severe brain damage. So in vitro studies suggested that this is possible,
mhm.
but When we studied this further in animals and in premature babies, we found that that really was not the case, that you needed much, much higher levels of lipids to actually cause that effect. It was also thought that these lipids could increase the chances of infection. That also was a dogma for many years in neonatology that was pretty much disproven.
So I'm still intrigued as to the process of disproving, if you like. So either you need some very brave neonatologist to say, look, I don't believe this. We're going to give, somebody's baby large amounts of lipids, or perhaps do you just sort of start increasing it little by little and see how you go?
Yeah, so I think that sometimes these dogmas persist for long, long periods of time. And in fact, the lipid dogma is still one that exists in many places.
Mhm.
And even though we've had these studies, cell culture studies, studies in animals, and studies in human premature babies, where we did prospective randomized trials of giving low lipids versus higher lipids, uh, uh, some of the dogmas that developed early still persist in some places. But I think that in general, the field of neonatology has really responded to evidence-based medicine
Mm.
techniques, studies that have provided new guidelines. For example, how much lipid, how much amino acid, how much protein we should be giving to these babies.
For which we need trials, retrials, meta-analyses in the usual way. So, Joe, I
Yes.
want to give you a chance just in a few moments to tell us about what fascinates you in relation to the future. But before we do that, it would be remiss of us, I think, not to ask you to just give us a summary of what is modern best practice for feeding the premature baby.
So there are guidelines, American Academy of Pediatrics guidelines, European Society of Pediatric Gastroenterology and Hepatology guidelines. These are written guidelines that many neonatologists are following. And in general, when in terms of macronutrients, providing an amount of glucose that maintains normal glycemia in the baby's bloodstream is what we try to use. Giving about 120 calories per kilo per day is a general energy intake guideline. That is provided primarily by giving the glucose through intravenous nutrition and lipid through intravenous nutrition, or by the mother's milk or the formula that we provide for the babies, giving about 3 to 4 grams per kilo of amino acid or protein per kilo per day.
Mhm.
Uh, and then also, we are recognizing that we need to provide iron to these babies after about 2 to 3 weeks after birth. Calcium and phosphorus is something that is so important because their bones are growing rapidly. And if you do not provide adequate quantities of calcium and phosphorus, it is these babies have a high propensity for development of osteopenia and also broken bones. It's very
Mhm.
difficult for a neonatologist to explain to a parent that
Mm, absolutely.
their baby's femur was broken because
Whilst in the
somebody
NICU.
tried to draw some
Mm,
blood from their
mm,
baby.
mhm. Absolutely, I can imagine. So, but you've just also summarized that in terms of oral intake, it would be breast if possible, mum's breast milk if possible, otherwise, banked milk, sometimes added with fortificants. I remember giving fortificants to my little one,
Yes.
and
Yes, yes.
then,
Fortifiers are very important to
mhm,
provide the adequate quantity of protein. So, for example, uh, baby's own mother's milk doesn't only provides about half of the protein that is actually required. So you have to add protein to mother's own milk, or we now have banked donor milk, which is very low in protein, and
mm,
we have to add protein to that. And there are various fortifiers that can be utilized for that.
Mm. Here in Africa, unfortunately, we have very few milk banks. So it's a real problem. But luckily, where NICUs are set up, there is, of course, the alternative of using a commercial preterm formula, which, because of the lack of milk banks here and because some mums just aren't able to produce the milk, then sometimes that can be a lifesaver. So, Joe, let's end on your current fascinations. I listed those a bit in the introduction, but where do you think, where is your research and where do you think the future lies in this area?
Sure. So I mentioned before that we have guidelines for
Mhm.
premature babies, and we use things like tools like growth curves to try to help us uh, ensure that the babies are growing adequately. But we're beginning to recognize that sometimes when a baby begins to falter on a growth curve, it's already too late. That damage has already been done. And so what we need to do is be more preemptive rather than retroactively
Mhm.
active. And one way to do that is to begin to use some of the tools that we have available to us, the artificial intelligence tools that we have available to us, to provide more precision nutrition. We're recognizing that a 32-week gestation premature is very different than a 23-week gestation premature in
Mhm.
terms of the nutritional needs. And a boy is different than a girl in terms of nutritional needs. And the type of environment that that baby comes from uh, through the mother, that leads to a difference in nutritional needs. So, for example, if the baby has been starved in utero because of placental insufficiency,
Mhm.
that baby is going to have different nutritional needs. So I think that we can begin to use some of these artificial intelligence techniques, such as uh, clustering. We have different forms of machine learning where we can cluster babies into much more refined categories than what we've had before. You know, before we've taken babies less than 1,250 grams, then 1,250 to 2,000 grams, and put them all into these very large categories.
Mhm.
But I think we can get much more precise than that using these clustering technologies. And even further down the road, when you talk about individualized for each individual baby, not just a cluster
Mhm.
of babies, we now have some technologies being developed that are called digital twin technologies that take a huge amount of data, and that data is stored. And then you have, and that is considered the virtual
Mhm.
or the mechanical twin.
Yeah.
And then you take the individual baby and you feed data from that individual baby into this large digital twin paradigm. And then
Mhm.
that shoots back information about how to best nourish that individual baby. So I think that this is a
Wow.
very exciting new area that we're getting into with artificial intelligence and also looking at the microbes that inhabit the gastrointestinal tract of these babies because they play a huge role in terms of metabolite production and growth. So I think that it's a very complex area, but we have some of the tools now, and these tools are being developed much more, very rapidly that will provide us with ways to become much more precise in the future.
Joe, I love this. And what a great place to end on the future. I can see I'm going to have you back in 20 years to do another milestone in terms of the development. But you know what? As you were describing that, and particularly the sort of digital twin bit, it reminded me of a notice that was up in the NICU when our baby was there. Watch the baby, not the monitor. And what you're telling us now is that through AI and these sort of processes, you can watch each individual baby incredibly precisely. And monitor and adjust its feeding regimen accordingly. Fantastic. And we look forward to greater progress. Thank you, Joe. The progress has been
Thank you, Andrew.
remarkable. The progress has been truly remarkable, and we thank you and all your dedicated colleagues, who work so hard and are so very dedicated to the care of these tiny little babies, for continuing to push the boundaries while simultaneously, as I say, working to give the babies the best chance in life. Now,
Thank you very much. It's been a real honor.
Oh, it's been my honor. Now, for any of you who are neonatologists and would like to take a deeper dive into these topics, Joe has hosted other NNI podcasts, which he has spoken to fellow experts about some of the more specialist issues. You can find them on the NNI 365 app. And thank you, listeners, for joining us in this edition of our podcast, Milestones in Pediatric Nutrition, part of the NNI Bites Big Learning series. Please do subscribe through the NNI website or the aforementioned NNI 365 app to ensure that you don't miss our future offerings.
Thanks for listening to Milestones. Explore more expert insights on the Nestle Nutrition Institute website and follow us on our social channels. See you tomorrow for another milestone in nutrition. Wishing you a season of learning and discovery.